Senator Carroll,
Here.
Senator Givens, Senator Harper Angel, Senator Howell, Senator Kerr, Senator Nemes,
Present in the room.
Senator Wise, Senator Meredith, Chairman Alvarado.
Present. All right. We have a quorum. We're constituted to do business. There's 2 items on our agenda today, or bills for consideration. The first one we're going to tackle is Senate Bill 68, an act relating to pharmacy benefit claim verification and declaring an emergency. I am the sponsor, so I'm going to come down to the table and let Chairman Meredith take over.
Thank you, Senator Alvarado. Appreciate you presenting Senate Bill 68 this morning. If you would, introduce yourself for the record and please proceed.
Yes, I'm Ralph Alvarado, State Senator for the 28th District. It's my pleasure to sit before you today to discuss Senate Bill 68. This is kind of a pharmacy benefit manager payment integrity bill. This is a similar bill to what was filed last year in House Bill 222. It was a bill passed by the House, I think, with 73 votes and had 15 co-sponsors. There was some concerns last year when this bill came that the new Medicaid PBM was just getting established, and they wanted to make sure that we could get it established before we considered this bill. And so this bill has been delayed, worked on in the interim, and it had a few changes to it. And so this bill effectively requires the Department for Medicaid Services to procure an independent service to ensure the accuracy and the integrity of Medicaid's new single PBM, as well as the Medicaid fee-for-service PBM. It complements Senate Bill 50 that was passed in 2020 to establish the single PBM. The independent monitoring entity will monitor 100% of pharmacy claims or invoices submitted by the pharmacy benefit manager and analyze the pharmacy benefit manager's compliance with state law and its contracts with the state and the MCOs. It'll help identify and correct errors in PBM claims to prevent the Department for Medicaid Services from overpaying the pharmacy benefit manager and to achieve savings for the Commonwealth. It'll identify and correct any underpayments or abuses, including any illegal or inappropriate fees imposed by the PBM on Kentucky pharmacists, and also provide thorough analysis and insights to DMS and to legislators on how each PBM is performing for the Commonwealth in its payments to pharmacists. Additionally, this bill will require the Personnel Cabinet to procure a similar monitoring service to ensure the accuracy and the integrity of the Kentucky Employee Health Plan PBM. These monitoring entities will provide analysis directly to the General Assembly so that lawmakers understand how the PBMs are performing with taxpayer dollars, and the monitoring entities' work occurs after the pharmacy has been paid. So the pharmacy gets paid, there's no disruption to pharmacists at all in that, and it's paid, and they're paid, and the work is done before DMS or the Employee Health Plan pays the PBM. So this is a real-time monitoring of 100% of pharmacy claims that would put the Commonwealth in a much better position to hold the PBMs accountable than the current audit process, which occurs after the PBM has been paid. Those are effectively the bill. I know the first part of it shows some of the requirements for the person that you're going to be contracting or the entity you'll be contracting with as far as the years of experience, and that we want it to be real time. That helps providers also know so that you're not having people trying to retroactively claim funds from you. And the third section there is we don't want an entity that performs annual retroactive audits, which often makes it difficult for providers in their cash flow. They've been paid something and a year later say, oh yeah, we're going to recoup that money from you. We want it to be done real time. I think it's a good bill. We've been working on it. It provides oversight for that. And with that, I would ask for the consideration of this committee.
Thanks, sir. Any questions from the committee? If not, I've got a couple for you, Senator Wise, or Senator Alvarado.
Sure.
It's been a long journey since Senator Wise, because he started Senate Bill 50 3 or 4 years ago, and it's amazing how this has evolved, because at the time when we talked about this, the thinking was, particularly from Department of Medicaid, there's no savings here. It is what it is, and we know we never have gotten a hard number on it, but anywhere between $250 million, $500 million. So this is a long way, but I think having folks overlooking this certainly gives us additional potential. But I particularly like the idea that we're going to do the Kentucky Employee Health Plan as well. Do you have any idea what they're spending on prescription drugs? Have you seen a number?
I haven't. I don't know exactly how much that is. I know we've heard from a lot of pharmacists. Some of the pharmacists I've talked to like that concept as well. But I don't have an idea of how much that is. I know there's an effort also in the House with a much larger bill to include all commercial PBMs, and that's a rather large bill. I think West Virginia's done something in that regard, but the House is trying to prepare a larger bill to cover all the commercial payers. But we know that the state employee health plan is something that has taxpayer dollars involved in that as well, and we thought this would be a good opportunity to provide oversight. And the pharmacists I've talked to like the concept.
Well, with adding 250,000 people during this pandemic to our Medicaid program, certainly placing additional fiscal constraints on our Medicaid budget, and that's expected. And I think every dollar that we can save certainly helps support these folks as we try to extend coverage for them. So I think it makes sense. Senator Wise, you have a question.
Thank you, Mr. Chairman. Senator Alvarado, thank you for the legislation. The question I have got, it came to me also from a local pharmacist in my district about the Medicaid auditor requirement portion of the bill. Can you go into more detail about that? This particular pharmacist had some concerns about that. I'm not sure if you're open to maybe having further discussions upon this meeting, but can you describe a little bit more about what that is going to do?
Sure. So I think it's under Section 1, and if you look at subsection 2, it says to be eligible to receive a contract pursuant to this section, an entity shall. And it goes into having at least 5 years of experience reviewing and auditing pharmacy claims and pharmacy benefit manager operations, be capable of performing the analysis of pharmacy benefit claims to validate accuracy and identify errors in near real time. So that will require a certain amount of technology to be able to say we can discover this quickly. One of the complaints we've heard in the past is that, like any provider, really, not just pharmacists, is that we do analysis a year later, 8 months later, and we say, oh, we think we paid you too much, and we're going to get a check from you or take it out of you at this point. Nothing frustrates providers more because we're very dependent on that cash flow to maintain operations. And so we're trying to get a real time. There are several agencies, at least a dozen, that are available that have, we've had similar procurements in other states like Ohio and Minnesota, where they've contracted with different agencies who can provide that service. We want somebody who can do it in real time, not be an entity that performs annual retroactive audits of pharmacy benefit claims for the public employee health insurance plan, and not be affiliated with common parent company or holding companies, share any common members of the board of directors or share managers in common with. And it goes through several insurers contracted through KRS 18A, third-party administrators contracted pursuant to 18A. I think a lot of this to eliminate any potential conflict of interest that we would have in some of those agencies. And they're going to be granted full access with contracts, all that information, so they can determine that things are being followed appropriately by the law and that payments are being made appropriately as well. So I think a lot of it is just to catch those things. The pharmacist is going to get paid. These guys will step in at that point, take a look at it, and then before the PBM gets paid, that's where the determination is made.
Thank you, Senator. I know we've done a lot of work. I want to thank our leadership for the work we've done to create that single PBM model. I think it's very good for other states to look at with us. I'm not sure if the cabinet's on the line, but also maybe the question to you, has the cabinet spoken to the single PBM that we're using about this piece of legislation?
Yeah, I don't know. I'll tell you, I have a weekly meeting scheduled with the cabinet. We had a meeting last week. There were only 6 bills assigned to this committee. This bill was not commented on, was not mentioned. No discussion about it at all. I received a text last night around 6 p.m., 5:30, 6 p.m., stating that, oh, yeah, we don't like this. We already have someone providing some of these services. And what they've informed me is that the University of Kentucky, that the PBM has contracted with UK to do some of this oversight. If UK is providing some pharmacy services, that becomes a bit of a concern there. I wasn't aware of that. I'm not sure if any of the members of the committee were aware of that. But that's one of the agencies. And then apparently the PBM has another kind of auditing service. I don't know what that entails. I don't know if it's real time. I don't know if they have the experience. I don't know if they can do things. Are they going to do retroactive audits? We don't have any of that information. I was made aware of that last evening at 5:30. Frustrating for me, but nonetheless, that's right. The information I have as of right now, currently. So I don't know if they've discussed it with a single PBM. From what I've heard is that they know that they're contracted with the state. They're willing to do whatever the state's going to require from them and work with us in whatever capacity that we determine they need to do.
Thank you, Senator.
Sure.
Senator Wise, Senator Alvarado, Kelly Rodman, I think, is virtual. And Senator Wise, would you like her to speak to your question, please?
Yep. Thank you, Mr. Chairman. Kelly, if you were able to hear that, I just want to know, has the cabinet spoken to the single PBM Med Impact about this particular piece of legislation?
We've spoken to them. We are aware we've talked to them. Just to, I think, clarify, the PBM Med Impact has the contract with UK. We do have a separate contract with that's already out there that monitors these types of claims. We testified in the fall when this was brought up that we had serious concerns with the issue. We did say earlier on that we would have liked to have a few more time, have more time to make sure that this would be a bigger issue. Getting into another contract does always have us in concern. But we will do as the legislation states. Obviously, I can only speak to the first part of the bill, which is the DMS part of the bill.
Thank you.
Yes, thank you. Senator Givens, you have a question?
Chairman, thank you. And I do have a question. And I want to first reflect back on Senator Alvarado's comments regarding the timeline, because I think those are very appropriate comments. If you look, staff provides us a front page that's attached with Senate Bill 68, and it provides actions like we often see on the website and in other places as the bill moves through the process. So on January the 10th, it was introduced in the Senate. On January the 18th, it was assigned to Health and Welfare. Leader Rocky Adams and myself, being in leadership, know the rigor with which we go through these pieces of legislation. Chair Alvarado, you know the rigor because you appear as chairman before us prior to every committee meeting to discuss the bills that you want to hear. I am certain in saying to you that you lobbied us to hear this bill a week ago. You asked for this to be on your agenda a week ago. We expressed some concerns and held it for an extra week. And then suddenly yesterday we all start getting calls from either groups that you've mentioned that have some concerns that have come a bit late in the conversation. That doesn't diminish those concerns, but the timeliness is certainly in question. A couple of quick questions, Mr. Chairman. Thanks for the opportunity to say those things. Senator Alvarado, say again to us, this bill almost identically passed the House last year?
It's similar. The bill last year was purely for the Medicaid PBM. It did not include the state employee health plan.
Okay.
So it was a similar bill. So it wasn't the same.
That vote last year was
73 to 24, and there were 15 co-sponsors on that. It was House Bill 222.
Okay. So now we have the cabinet and others expressing some concerns, and it's, again, not inappropriate for them to do that, but it sure would have been nice to have had those concerns raised 3 or 4 days ago or a week ago. Ms. Rodman, you mentioned those were raised back in the fall. Share with me again, no intent, just questions, trying to understand, Ms. Rodman. Help me to understand the contractual arrangements that everyone seems to have in this space. We have Med Impact, who has a contract with the cabinet, correct?
Correct.
And then we have Med Impact that now also, we're told, has a contract with UK.
That is what I've been told. Correct.
And the purpose of that contract, to your knowledge, and again, understanding this is solely to your knowledge, is what's the purpose of that contract?
The way I've been explained it is to check to make sure that all the claims are being paid appropriately, and to make sure that Med Impact and the pharmacists are being paid back and forth. There's a communication there.
Okay.
But I have not seen that contract, so I do not know.
Sure. Thank you for that. And then you indicate the cabinet has a contract with someone doing a similar thing?
Correct.
And who is that?
And I apologize. I understand there's a timing issue here. There are a lot of bills that we have to go through, and yes, we get behind. And I will admit this was one that fell through the cracks on my hands, so I will fall on that one.
Well,
I do need to get a little bit more details on that contract, because I don't even know who it's with. So I do need to get more information on that one and get back to the committee.
Okay. But you feel like that contract is also to ensure integrity in the payments and the dollars and the values?
Correct.
And those sorts of things. Well, I appreciate your statement that you'll certainly do whatever you're told to do with regard to the legislation that makes it through the process, and I appreciate your response to that. That's a very appropriate response. And so if this moves on, then you may have to take a look at that Thank you for that information, Mr. Chairman. Thanks for the bill.
Thank you.
Ms. Rodman, while we're on this subject, are either of those contracts that we're referencing, are they real time?
I would need to check on that.
All righty. Are any of them related to 340B? Is that what's precipitated this?
I will need to check on that one as well.
All right. Thank you.
Sorry, I'm not prepared to answer that deep of a question. So
No
let
problem.
me check on that one as well.
I do not mean to put you on the spot. We appreciate
No problems.
how difficult life is for all of us right now. Senator Berg, you have any question?
I do, Chairman, and thank you. And I don't mean to sound ignorant, but I was taught if you don't understand something, ask a question. So I am confused here. We currently have contracts to oversee medication management and distribution. Is that correct? I mean, like, when I think of a PBM, I think of, somebody calling me and saying, this drug costs X, Y, and Z. This drug costs, A, B, and C. We think this drug may work. We'd like you to try it. That type of stuff. That's what I think of when I think of a pharmacy benefit manager. This is different. You're looking at payment to pharmacies real time. Is that correct?
Yeah, what you're describing is a prior authorization process for doctors. This has nothing to do
No,
with
not prior authorization. I'm talking about pharmacy benefit management, like UK. Like, I had a problem with one of my prescriptions. The pharmacist called me. My doctor wrote a script. It was non-formulary. They didn't want to cover it. Pharmacist calls you, talks to you directly as a patient, gets in touch with your physician. You make a concerted decision together, and you try this drug. That, I'm insured through U of L. We have a pharmacy benefit management through UK that is a service that actually, when I first ran into it, I found very obtrusive. But over time have realized, oh man, they're right. I mean, one of the drugs I was on went from $200 a month to $13 a month just by switching. So that's a good service. I like that service. This is totally different. This is looking at how much pharmacies are paid.
That's right.
Real time.
That's right.
And why as a legislature do we care about that?
Because we're contracted with we run a PBM now for Medicaid. If you may want to go back and read Senate Bill 50 that we passed a couple of years ago.
I'm aware of Senate Bill 50, and I'm aware also that I've got people writing me, saying this contradicts Senate Bill 50, or let Senate Bill 50 work for a while. It's working. It's just been 6 months. Give us some time. We think this is going to be just another layer. So I'm trying to understand. And I apologize for not understanding this situation, but I'm really trying to understand, why do we need this?
Mr. Chairman, if I could respond? Thank you.
Thank you.
So again, what you're describing as a patient and what happens is a prior authorization process. It's nothing to do with PBM payments to pharmacists. So if you
Okay.
read the bill, this is a discussion of what happens when you reimburse pharmacists. Pharmacists get reimbursed based on their medications. It's a totally separate thing than what patients have to encounter with their doctors or what doctors have to appeal for from a pharmacy through a PBM process for prior authorization. So traditionally what this does is it's basically helping us oversee the single PBM that we've established here in the state of Kentucky. If you're familiar with Senate Bill 50, then I assume you're educated on that topic. We have a single PBM now for Medicaid. Who's providing oversight for that is the question. Are they doing payments properly? Are they not doing payments properly? We found out today we have two separate agencies. Apparently the University of Kentucky is one who also provides pharmacy services in the state. And then you've got a separate agency that I'm not even aware of who that is that's doing that. We don't have much detail on the contracts. We're finding that out today in the last 18 hours. I'm sure we'll get more of information about that here in the next few days as to who does that, what oversight is being provided. When there's a payment being done, you go for a point of service. A pharmacist gets paid for that medication, then the PBM gets paid afterwards. So there's a lot of transactional issues. It's a very complicated, very opaque process that we've tried to take the lid off of here in the state in the last several years. Senate Bill 50 did a lot of that and reformed a lot of that for us. We've also taken away MCOs from having their own PBMs to manage a lot of these things. We've established a single PBM, but who's providing oversight for them to make sure that those payments are accurate? What we don't want to happen is what we've happened in the past is that we issue a payment to a pharmacist and say, oh, we've overpaid you, or oh, we've underpaid you. And that's happening. And probably underpayments happen a lot more than overpayments do for pharmacists. But to be able, instead of having to recoup that a year later, like we've seen, as many providers do in the medical field, is to do that real time, so that when they, as the everything is being entered into for the contract, an agency can have that real time say, okay, the pharmacist has been paid. Was that transaction accurate? If it was, great, nothing happens. If there's an inaccuracy, they've been underpaid, they can say, this has been an underpayment, and it gets corrected in a matter of days, versus having to come back later and say, hey, we've shortchanged you, we've overpaid you, and you don't have a lot of those cash flow concerns that we've had from other providers in the past. So this is going to help get that do it real time is the basic thing, so that you don't have a lot of those transitional problems that pharmacists have had in the past. A lot of it's transaction with pharmacists more so than with providers or patients or prior authorizations or anything along those lines.
All right, thank you for that explanation.
Sure.
Just for Senator Berg's information, Senate Bill 50, the genesis of it was appropriateness of payment. That we found that contrary to the contracts with the MCOs, that our independent pharmacists were not being paid appropriately. They were not getting their costs. They were not getting the transaction fees. So that's where it started. And we were told at that point in time that they're really not a problem. Senator Wallace and I both determined, without any real data available to us, that anywhere between $250,000 and $500,000 or $500 million in fees were really we couldn't account for. And that's why we passed Senate Bill 50. And I think the thing that makes this unique, and Senator Alvarado, you probably need to touch on a little bit more, is that with this relationship we're looking at, this entity will report to the General Assembly.
That's correct.
So it's another check and balance on this whole entire process. In the way that it's structured in payment, we're not out any fees unless there's a savings realized from recognizing the overpayment and underpayment for these services. So I would just add to that. But with that, Senator Danny Carroll, you have a question, comment?
Thank you, Mr. Chairman. Senator Alvarado, appreciate the bill. Couple things that concern me, and I think the duplication of services is what we need to be concerned with right now. And I guess I don't understand why UK would be providing these services for Med Impact, and I guess I see the value of them wanting someone to double check the process and the payments that are going out. I guess I didn't realize UK did something like that. But still, I would not want to depend on anyone that the PBM hired to do that themselves. I think with the cabinet's contract with this company, I'd like to know more about that, and I think it might be to everyone's advantage if in fact that organization, that company is basically providing the same services, not in real time. And I completely support the real-time aspect of this, as it's much more efficient in the long run. So I don't have any issue with that. But maybe we need to find more out about this company and that contract. And if we implement this process, we need to make sure that that contract is not renewed at the end of the service period, so we are not having a duplication of services. And I know it's not any more money to the state to hire this new company, but the issue is they would be making money off of the state for services that may already be provided on the tail end of the services. So if we pick up one, I feel like we need to drop the other.
I would agree.
Okay.
I would agree, Senator.
Second by Senator Nemes. Motion was by Senator Adams and second by Senator Nemes. All those in favor of the motion vote aye. All opposed vote no. Please call the roll.
Senator Rocky Adams. Senator Berg.
I'd like to explain my no vote.
Please.
I am sorry. I really, I went through the legislation last night. I've read my emails. I don't understand this enough, and I'm concerned this may be just an extra layer that we don't need, that we may already have. I'm going to vote no now, and I'll look into this further. Thank you.
Senator Carroll.
Mr. Chairman, I'd like to vote aye for now. May I ask Kelly Rodman another question, please?
Yes. Kelly, are you still with us?
Yes, I'm still here.
I'm sorry, Senator. We can't do this during roll call.
Okay, Mr. Chairman, I vote aye. However, there is other information that I would like to have access to that Kelly, Ms. Rodman can provide.
All right, thank you.
Senator Givens. Senator Harper Angel.
Explain my aye vote, Mr. Chairman.
Yes, please.
It sounds to me that the meat of this bill is live time, which is always excellent. But what's disconcerting to me is that we have these contracts that we as the legislature don't even know exist, and we can't get answers as to whether or not they're even live time. So I vote aye, and I want to move the bill forward. Thank you, Mr. Chair.
Senator Howe.
Aye.
Senator Kerr. Senator Meredith.
Aye.
Senator Nemes.
Aye.
Senator Wise.
Excuse me, vote aye, but I look forward to having more conversations with the cabinet. Thank you.
Chairman Alvarado.
Aye.
The vote is 10 aye, 1 no. That passes with favorable expression. Congratulations, Senator.
Thank you, Mr. Chairman. Appreciate that. Next on the agenda, we have Senate Bill 8, an act relating to child welfare and declaring an emergency. The sponsor is Senator Julie Rocky Adams. I know we have quite a few individuals who are present in person and remotely. And if they're going to come forward and present, I'll allow them to introduce themselves when the time is right. So, Senator Adams, whenever you're ready.
Thank you, Mr. Chairman. And again, I'm Julie Rocky Adams, Senate District 36. And I hope that you all will bear with me. This is this is a bill that's been really a labor of love putting together. It's been quite a long journey all during the interim. And so my testimony is going to be exhaustive because we are looking at a 49-page bill. So I want to make sure that the committee has all the information that they need to make an informed vote today. So child welfare belongs to all of us in this room. We all play a role in child welfare. So the purpose of this bill is to address various child welfare matters and expand child abuse and neglect prevention services. Kentucky has led the nation in child abuse and neglect for 3 consecutive years. I know you all get tired of me saying this, but now it's time to make a change to that statistic. While the General Assembly has made great strides in foster care and adoption issues over the past several years, our rates of child abuse and neglect continue to cause great concern. Just last week, there were new reports out about the significant increase in child fatalities and near fatalities in Kentucky during the past year. We are all aware of the overwhelmed workforce we have with our social workers in DCBS. And many of these issues will require additional investments in our child welfare system. Senate Bill 8 has been crafted to primarily address child welfare policies and practices that will complement these much-needed investments. Senate Bill 8 has been designed in a manner that should unite all of us, as it incorporates input from our Attorney General's office, our Cabinet for Health and Family Services, our Administrative Office of the Courts, our child welfare providers, our advocates, and our foster youth. So if you take a look at the bill, sections 1 through 9, these amend various sections of KRS Chapter 15 to expand the scope, membership, and functions of the Child Sexual Abuse and Exploitation Prevention Board to include all forms of child abuse and neglect, including sexual abuse and exploitation. The board will now become the Child Abuse and Neglect Prevention Board. This expansion is really, I think, a dynamic change in how we are doing things across state government. And today we have Heather Wagers, who's going to pop up at the table with me, introduce herself, and give a few-minute testimony on this particular section of the bill.
If you could please introduce yourself for the record and make sure that your microphone is on there.
Good morning. My name is Heather Wagers, and I am the Executive Director over the Office of Trafficking and Abuse Prevention and Prosecution for the Office of Attorney General. And so we are very appreciative of Senator Adams' attempt to try to bring the focus back to child maltreatment. All forms of child maltreatment is a problem in Kentucky. It's not just one single type of maltreatment, and I looked at other child victims trust funds across the country. The majority of them are focused specifically on all 4. physical, emotional, verbal, and sexual abuse. And so we are an outlier in that we have a board that's only focused on one form of maltreatment. Ohio, Tennessee, West Virginia, Indiana, Missouri, Michigan, and Wisconsin are some of those that are surrounding states that have all focus on all forms of maltreatment. In Wisconsin, they are leading the country in attempting to reduce the incidence of abusive head trauma. Abusive head trauma, or shaken baby syndrome, is the leading cause of child abuse in the country. We're not able to put forth preventive efforts towards that here in Kentucky with this board until this change comes about. And so we appreciate the opportunity to have that expansion. We worked with the senator in the summer, and we put this question to the board, and the board voted that they were very interested in the expansion of the scope.
Thank you. Appreciate it. And you might have to come back for questions if they have. Okay, we'll move on to Section 10, and this amends KRS 194A-010. And this clarifies that the Cabinet is responsible for administering child welfare programs that promote collaboration and accountability among government agencies and public and private programs. This amendment to this section is intended to promote collaboration with our community partners and other organizations, such as the Child Abuse and Neglect Prevention Board previously mentioned by Ms. Wagers. Section 11, it amends KRS 199-011, and this expands the definition of fictive kin. And this includes individuals who have an emotionally significant relationship with a biological parent, sibling, half-sibling in the case of a child from birth to 1 year of age. So this change conforms with the same definition of fictive kin in Section 17. The next couple of sections, these were all recommendations by the Cabinet for Health and Family Services. So Section 11 was from CHFS, Section 12 is too, and that amends KRS to clarify that the Cabinet has 5 business days to submit an affidavit verifying if someone is registered on the punitive father registry. And then if we move to Section 13 and 14, these are also CHFS. They amend KRS 199 to remove the ability for adoptive parents to annul an adoption based upon ethnological ancestry differences with their adoptive child. I can't believe this was even in our statutes, but it is time to clean up that particular section. Section 14 amends KRS 199 to clarify that adoption files and records can be stored in a digital file with restricted access. Okay, so now we're moving into Section 15, and this, to me, I think is one of the most significant portions of the bill. This amends KRS 200-575. This expands the ability to provide family preservation services to children who are at moderate rather than actual risk of out-of-home placement. This is a key provision toward preventing child abuse and neglect. Our laws have to allow for the ability of DCBS and our community partners to work with families before the abuse and neglect occurs. So with this change to moderate, this is really significant because we can get in there and help this family heal so that we can keep that family whole and we can have them heal. Next up is Section 16, which creates a new section of KRS Chapter 205, and this requires Medicaid reimbursement for child medical evaluations at our child advocacy centers. And this will reflect the true and actual cost of the actual evaluation. This provision has been developed in consultation with our child advocacy centers in Kentucky, the Department for Medicaid Services, and they have not updated their regulations and reimbursements for our child advocacy centers in 20 years. The Cabinet also has conflicting regulations among departments. So Medicaid regulations only acknowledge medical evaluations by physicians within our child advocacy centers. And DCBS regulations acknowledge medical evaluations by physicians, APRNs, and SANE nurses. This provision is needed to address the conflicting regulatory standards for child advocacy centers and CHFS, and finally compel the Cabinet to adequately fund their services. Otherwise, these funds will continue to be diverted from the Child Victims Trust Fund that is administered by the Child Abuse and Neglect Prevention Board that we described in sections 1 through 9. And I have some folks from the Child Advocacy Centers here that are going to do a quick testimony as well, and if they could make their way to the table.
If you ladies could please introduce yourself for the record as well, and then provide your testimony.
Thank you. Good morning, and thank you for this opportunity to speak to you all about the critical need to fund medical services at the Kentucky Child Advocacy Centers. I'm Pam Darnell, CEO of Family and Children's Place, which is headquartered in Louisville. And our Child Advocacy Center is one of the network of 15 child advocacy centers across our state. There is a child advocacy center in every area development district which serves all counties. And the Child Advocacy Center at Family and Children's Place serves Bullitt, Henry, Jefferson, Oldham, Trimble, Shelby, and Spencer counties. Our network of child advocacy centers serves 7,500 child victims and their caregivers every year. These children that we serve have experienced sexual abuse, physical abuse, human trafficking, and neglect. And we all know that child abuse is hurtful and traumatic, but these child advocacy centers every single day see the most severe cases with these children. Our centers provide special forensic interviews, mental health services, advocacy, and importantly, all 15 centers maintain medical clinics where a victim can receive a special child abuse sexual assault exam. When the statewide network of CACs was created over 20 years ago, the state also established medical clinics as Medicaid providers to allow these centers to be able to use federal funds to help support the cost of medical services. But unfortunately, Medicaid is no longer a viable funding source for these services for several reasons. First, the types of services outlined in the current Medicaid regulations are extremely narrow and restrictive, and they do not cover all of the services that take place at the centers that these children need. In addition, it only allows reimbursement for one very specific set of services. And if any one of those services is provided outside of a very narrow time frame, the entire evaluation is not able to be billed to Medicaid and will not be funded. The regulation also does not allow for reimbursement of all qualified medical professionals that serve children at our child advocacy centers. And the reimbursement rate for one of these exams is $538. And as Senator Adams said, these rates have not changed in 20 years. But Senate Bill 8 fixes a lot of these issues by expanding the services that Medicaid will cover at our child advocacy centers to increase the rate and the true and actual cost of these medical exams. To give you all an idea of what this means financially for child abuse, for child advocacy centers with these exams, a typical exam costs the Child Advocacy Center $2,100 per exam. Medicaid reimbursement is $538. We are very grateful to the Child Victim Trust Fund program for the $100 that it provides for every exam. But the rest of that is covered by the CACs through private fundraising and sometimes if there are other state grant dollars available. So we really have an opportunity with Senate Bill 8 to leverage more federal dollars to fully cover the true cost of these exams so that our child advocacy centers can continue doing this work that nobody else does to help these kids in our state who need the service.
Good morning. Thank you for the opportunity to speak on behalf of the Network of Children's Advocacy Centers of Kentucky. My name is Jacqueline Sugarman. I'm a board-certified child abuse pediatrician, and I serve as the medical director for the Coalition of Children's Advocacy Centers in Kentucky. I also work at the Children's Advocacy Center of the Bluegrass in Lexington. I've conducted over 2,000 child sexual abuse medical exams at children's advocacy centers in my 30-year career as a pediatrician. I feel like Senate Bill 8 allows me to do my job without worrying about how it will be funded. CAC medical professionals provide a very specific type of medical service for children who have experienced sexual abuse. We provide comprehensive, trauma-informed, developmentally appropriate medical examinations that really start even before the child ever enters the examination room and conclude long after the child has exited our building. What do I mean by that? First of all, in order to do the exam, we have to obtain a lot of information from investigators, from the caretaker, for the child themselves. And then we also have to obtain a medical history, a social history, a family history to ensure that all the child's needs are met. It also requires that we assess the child for injury, infection, and then entertain other diagnoses that might mimic abuse, because we don't want to, there's a lot of stakes in making the wrong diagnosis here. In some cases, we even have to collect forensic evidence from the child's body. So the healthcare provider, at the end of the day, has to also be able to communicate the findings and the impression of that exam with other community partners that we work with in order to keep the child safe. And this communication extends beyond the medical clinic, sometimes all the way to the courtroom. It requires a great deal of time, something that's truly undervalued in our current Medicaid regulation. Many CAC medical professionals have other jobs, and they choose to spend some of their work week at the Children's Advocacy Center because they feel a responsibility to serve the children and the families in their communities. Many of them volunteer additional time outside the exam room. They communicate with community partners so that law enforcement, social workers, and prosecutors can successfully perform their jobs. And when our medical professionals provide court testimony, they often have to take time away from their other jobs and even cancel a busy office to go and testify in court. Most children who experience sexual abuse would not be able to receive a trauma-informed, developmentally appropriate medical exam by a qualified professional at a CAC if the medical clinics didn't provide them this opportunity. Unfortunately, as Senator Adams said, some of the vital services that the healthcare providers perform at CACs are not outlined in our current Medicaid regulation. For example, follow-up examinations, which involves reassessing an area of concern that was identified at another exam, or assuring that appropriate treatment was completed, or identifying additional necessary treatment, are not covered. Another thing that's not covered is the diagnosis and treatment of other medical conditions and sometimes mimics of sexual abuse that are commonly identified at CACs as well. So I feel like Senate Bill 8 fixes these problems. We know that from emerging science on adverse childhood experiences that unaddressed sexual abuse can lead to chronic health problems down the road, including heart disease, cancer, and obesity. We also know that sexual abuse victims can suffer low self-esteem, suicide attempts, academic difficulties, and school failure. They can abuse illegal substances and become victims of prostitution. Sexual violence, therefore, is costly not only to the victim, but to society and to the Commonwealth and all of us. According to the CDC, the total lifetime economic burden of child sexual abuse in the United States in 2015 was estimated to be $9.3 billion. The work that CAC medical providers do provides more than a diagnosis on paper. Not only does it provide the physical and emotional healing for the individual child and their family, but the medical professional's expert opinion is an essential component of the investigation and the court process. And this ensures not only the safety of that individual child again, but may protect other children who are at risk of abuse if a perpetrator is not stopped. So in conclusion, Kentucky must fund this work properly, and Senate Bill 8 helps to do that.
Thank you, ladies, for your testimony. Okay, committee, I'm going to hustle through this. Okay, we're on Section 17, and Section 17 was designed to clarify that abuse and neglect occurs when a parent or guardian does not provide adequate care, supervision, clothing, shelter, and education of the child and has the financial means to do so. This provision is an essential piece of Senate Bill 8 as it separates the idea of poverty from neglect. This particular language is modeled after other states with similar provisions within the neglect definition. So the next few sections, these are more of conforming language type of housekeeping bills or housekeeping items. So we're going to expand the definition of fictive kin to include an individual who has an emotionally significant relationship with a biological parent, sibling, half-sibling in the case of a child from a birth to 1 year of age. The next section is conforming language as well. That includes the State Child Abuse and Neglect Prevention Board and Health and Welfare and Family Services Committee to the list of entities that receive the annual report of the External Child Fatality and Near Fatality Review Panel. In Section 19. Now, this section, we have people from the Voices for the Commonwealth. Then they're going to come up and do a little testimony, too. This section amends KRS 620 to allow foster youth to request to extend their commitment prior to attaining 20 years of age and opt in or out of extended commitment up to 2 times. This provision was developed in consultation with our own foster youth here in Kentucky and former foster youth with the Voices of the Commonwealth. Section 20 adds new rights to the foster children as it relates to their case history with the cabinet placement, connections to siblings, and parenting their own children while in care. And this was also developed with the Voices of the Commonwealth. And take it away, ladies. Please introduce yourself.
Morning, everyone. There we go. The mic's on now. My name is Tamara Vest, and I actually serve as the current independent living coordinator for Murray State University. And out of that university, we run the program, the Voices of the Commonwealth. So I actually reside in Nicholasville. I'm not from Murray. I'm just employed through them. And I served as a youth advocate on the Voices of the Commonwealth for about 3 years. And during those 3 years, I did a lot of policy advocacy, specifically with the tuition waiver last year that you guys have seen and with the Bill of Rights back in 2018. And I actually served as chairperson for about 1.5 years of that council. And now my colleague here has succeeded me as chairperson. So you will hear from me in my new role, and I'm here showing her the reins today of how this works. So in regards to Senate Bill 8, I wanted to speak on the changes to the extended commitment statute. It currently states that a youth who is in foster care who wants to extend their commitment to the state of Kentucky, to the cabinet, has until their 19th birthday to do so. So they can extend when they're 18, they can leave during that year, and they have any time until their 19th birthday to make the decision that they want to come back, or they can choose not to extend when they're 18, and they still have the option to make that decision to return to care by their 19th birthday. Now, I've done a lot of research before we developed this request, and over half of the states in the United States are actually offering similar to what we're asking for. And what we're asking for is that that time period be extended to their 20th birthday. And the reason for this is because a lot of us have personal testimonies where we believe that the 19th birthday is just not enough time for individuals who have been through the foster care system to really get out there on their own, make mistakes, and realize that they may actually need support. So in saying that, I actually spent 9 years in the foster care system myself, aged out at 18, and I did not extend my commitment to the cabinet. When on my 18th birthday, I did not extend, so I left when I was 18. I was that hard-headed 18-year-old who had been 3 years of foster care, had my life controlled, and was ready to be in control of my own life and my own decisions. I learned very quickly over the next year that it is so hard when you age out of foster care without those supports and those connections who are going to be there to help you as a young adult, working through your trauma, trying to go to college, trying to work jobs, and it's very hard without that extra support, and specifically, I mean the financial support that these programs can provide for housing and for other things that you need as a young adult, and the emotional connections that they can provide while you're in the programs. So I actually requested to return to care on my 19th birthday, and I was told no. I was told no because I was already 19, so therefore I did not get the support that I could have gotten if I was able to return to care. Now, with that being said, the statute says that an individual who recommits to the state is able to stay until they're 21. So I'm not understanding why we are capping their decision to return at age 19. If you have until your 20th birthday, if you recommit on your 20th birthday, that's a whole extra year of support that you could receive, which is vital to these young people. If you commit anywhere between your 19th and 20th birthday, that's over a year of support that is vital to these young people. So I just want to make sure that we're setting up these individuals, these young adults that have been through the foster care system, setting them up for success to be young adults and successful citizens for the Commonwealth.
Good morning to all. My name is Taylor Trent, and I'm the chairperson of the Voices of the Commonwealth. I personally have spent over 10 years in the foster care system. Speaking on behalf of the Foster Youth Bill of Rights, my team and I have heard feedback from many of the youth currently in foster care throughout the state who mentioned that they felt as though many of the simple rights may need to be may be missing from the document. My team and I believe that the amendment of the Bill of Rights will help ensure that youth are having quality experience in foster care by giving them the right to request a placement where they feel comfortable and safe. Allowing them the right to participate in court hearings of siblings and half-siblings ensures that they are connected in every way around them and that nothing from them seems cut off. The Parental Rights Clause allows foster youth who are in care to feel comfortable in knowing that they will not immediately have a child removed from their custody, and allow them the comfort in knowing that they will have the right to make parental decisions on their child's behalf. Lastly, ensuring that all youth who exit care have the right to receive any and all vital documents regarding their time in care, the health and well-being, allowing youth to develop and to ensure their identity when becoming a young adult and their safety around their own health. My team and I believe that many of these rights are unquestionable and necessary for a better quality of care for children and in the Commonwealth. Thank you very much.
Thank you, ladies. That was very nice. Very well done. And then just to wrap it up here, the last section 21 is just the section on the personnel cabinet requiring them to update their administrative regs on the Kentucky Employee Charitable Campaign to include the Child Victims Trust Fund, which you all have heard me speak about before on the floor of the Senate. And then lastly, this has an emergency clause on it. I think that that is important to put in there because it shows our commitment to identifying this as such a significant barrier to so many successful lives in our Commonwealth. And so with that, Mr. Chairman, I'm happy to take any questions. And if anyone has anything specific for my guests that I have, please let me know and they'll be happy to answer.
Senator Adams, thank you. I'm a proud co-sponsor of this bill, and really we're going to hear a lot of things this session, and I would argue this is probably the most important bill we passed this year. And it's not the final step, it's just the first step. I think a lot of us are unhappy with our ranking as a state. We know we have a lot of work to do. It's a big bill, a lot of input, and I commend you for that. It's been a lot of work done. I know there's been an interim task force. We're trying to elevate this, obviously, on the level of importance. Our children are our most vulnerable. I'll tell you, as a provider, shaken baby syndrome, huge issue. You hear about it. When you're a pediatrician, you see those kids. You find out after the fact they've got retinal hemorrhages and damage to their vision that'll be permanent a lot of the times. The damage, obviously, most of the time it's irreversible. Just a moment for parents who are often good people, who have a crying baby, they're young, they don't know what to do. And a lot of it's just education. Is when I've talked to a lot of parents and tell them, hey, listen, you're going to have, anybody who's had kids knows you have those moments. And I tell them, if you feel like you need to act out, have someone come in, watch your kid, go take a walk, go diffuse, go do something. And I've given that advice to lots of people over the years in hopes that if they ever get to that moment where they take an action of anger or something, that it'll affect them for the rest of their lives, their child for the rest of their lives. And so a lot of these things often is just education for people to know coping mechanisms. And I also commend you on Section 16 of this, Dr. Sugarman. I appreciate the work that you do. Part of my training at UK was going to these clinics to provide these exams, very delicate exams, very sensitive, children at a very young age, difficult exams to do, sometimes with, the things that you find are devastating. And it's important that we provide adequate exams for these children. And often those exams are what leads to the information we need to prosecute those who commit these crimes. And it's important that we get these done accurately, quickly, and that we have providers who are willing to do that. It's a difficult task, so I commend you for that. We do have a few questions. Senator Givens.
Mr. Chairman, thank you. Leader Adams, thanks for this legislation. Your passion around this topic is something all of us know and appreciate and applaud, and we need your leadership so vitally in lots of places, but especially in this place, around an issue, as Chair Alvarado indicated, is a super sensitive topic that we've got to get right. We've just got to start getting better at this. So thank you for the legislation. I specifically have questions around your Section 16, and if your folks from the Children's Advocacy Center could come back to the table to address those questions, that would be great. In your testimony, you indicated current Medicaid rate is about $530 per exam. True cost is $21, $23, somewhere in that range.
$2,100 is the average cost per exam.
How many of those exams are performed at children's advocacy centers a year?
The total is just around 1,000 last year.
Okay. Are these sorts of exams provided anywhere else other than children's advocacy centers, or these sorts of exams happen solely at CACs?
Well, sometimes children show up at different locations and get evaluations. The extensive evaluation that happens, I would say, happens at the Children's Advocacy Center. I mean, sometimes children show up in the emergency department, so they are evaluated at the emergency department. They show up in their doctor's office, as Senator Alvarado knows. That's how things happen. But the comprehensive exam is really done at the Advocacy Center, and that's one of the reasons for the follow-up, because sometimes the initial exam is not the exam that the child needs, or the follow-up, what we call a follow-up exam, is really the more comprehensive exam. And right now we don't really get reimbursed for some of that follow-up that we're doing. So the crux of my question is more related to geography than anything else. Mm-hmm. I pulled up your map while we're talking. The services you provide are obviously vitally important. Sadly enough, there's not even a satellite location in my Senate district. So children in my Senate district, it's highly unlikely that they're going to land at your facility first. That's just the reality of the geography and the access. Those families that are facing this horrific set of circumstances are likely going to end up with the child either at their primary care physician, I would presume, or at the ER. Help me follow the path. And here's my concern. Obviously, the thoroughness and the knowledge that you have around this sort of exam is something that
that is housed mainly with you from the way you've explained it, and I applaud that. We need that there. I'd love for my folks to have access, my providers to have access to the highest level of compensation that Medicaid can provide for them to do to the limit of their abilities, and then pass it off to you to finish the process. Because you mentioned earlier in your testimony, timeliness is critical. The timeliness from this incident or series of incidents to the exam is something that would be vitally important, I would think. And we hear Senator Meredith often in this committee and in other committees talking about pay disparities between rural and urban medical delivery models. So if there's a way, I'd like to work with you, Leader Adams, to broaden this so that we provide access at a fair compensation rate to all of our providers that can meet these needs, and then maybe continued services around support at your facilities where the geographic access is not there for my constituents. Thank you.
I love your comment. I'll be happy to do anything I can. Thank you.
Thank you. Very good. And Senator Givens, it's the process may have changed. It's been a while since I've worked UKER when I was a resident. I know that we would often have cases of, and this may get a bit graphic, but children would come in. There's a concern of a sexual abuse or sexual assault of a child. That you'd have to do a preliminary exam to collect evidence, be a rape kit that you would do, have to be in the presence typically of law enforcement, they'd have to be taped, signed off on, passed on to make sure no evidence was tampered with. A referral then would be made to an advocacy center for a more, and there, unfortunately, the things that occur, a more detailed exam is done. There's concerns about things like vaginal penetration. Is there an intact hymen or not? Photographs are taken of that as evidence. Those are pretty high resolution photography that's done of those kinds of things. Those are things that can't be done in ERs, in doctors' offices. If someone's brought a child to me, says, I'm concerned that this has happened to my child, you do a preliminary examination, you do some of those things, but to take those kinds of photographs, collect that kind of evidence, do those detailed exams are difficult to do. So often you see these children after the assault has occurred as a referral from a primary care doctor or an ER. Things have settled down, but obviously the information that's collected there is of crucial importance really for cases that are being brought against perpetrators to make sure that justice is done. And it's something that I've seen too much in my career. Other doctors have seen too much in their career. And again, that's why I think this will be the most important thing we do this year. Senator Howe.
Thank you. I just had a couple of follow-ups on Section 16, building on what Senator Givens had. First of all, Dr. Sugarman, thank you for your support on this. I deal with kids a lot in this situation through the court system. You have a lot of background in this area that far exceeds your training as a pediatrician. The people that are providing these services, it's better for them to have some more specialized training to deal with the pediatric abuse aspects of it. Do we have trouble getting enough qualified, specialized people in these areas to do this sort of work? Is that a problem that we have? I don't know who to address this to, but...
Yeah, well, I do think that that's a challenge. So recently, or over the years, I mean, since I started, there is a national accreditation for children's advocacy centers, and the majority of our children's advocacy centers are accredited. There are certain requirements that they have to meet, and some of those requirements are centered around provider training. So the providers that work at children's advocacy centers have to have a certain number of training hours in child abuse and child sexual abuse. We just got done in December providing a 8-hour course to our providers around issues of updates and updates on sexually transmitted infections and medical finding updates. So we do frequent trainings to make sure that people are qualified that work at children's advocacy centers. It is a challenge to find people to do the work. And part of that challenge, though, has to do with the time-consuming nature of the process. And, if you're in private practice or you work somewhere else, it's often difficult to, take that time to do these exams. And as I said, part of it is also because it's not just the exam, it's the after work that you have to do, the calls you have to make to the investigators and prosecutors, and then, if you have to go and testify in court. So it's all that other work that you have to do in addition that's time consuming.
Thank you. That's kind of the lead for my question. I'm assuming that another reason that we have trouble getting qualified people, to Senator Givens' point, in my area, we don't have a center either. In more of the rural areas, this isn't serviced as centrally even as it is in your areas. It takes a lot more time. Time and volume is money for medical providers, and you have to take grossly more time with each one of these cases. And is it your opinion that part of being able to increase this reimbursement will be able to it'll make it easier for more and more specialized providers to move into this space?
I would agree that it would. And right now in Kentucky, the last number I heard in the whole state, we have 4 board-certified forensic pediatricians with the forensic specialty. And so, as Dr. Sugarman has so well said, it's really difficult to get people to want to do that work. And often people want to do it and they volunteer a lot of their time because they don't get paid for some of the additional time. So it is really difficult work to sit in here and then to have to do these exams for kids who've gone through some of the things you and I will never know. And I will also add, if I can, our state legislature was very forward-thinking back in the late 1980s and the early 90s when the state legislature mandated we would have a child advocacy center in every region of our state. And it would be wonderful if we could talk about how do we increase for those areas that still don't have good access.
Thank you, Senator. You want to continue? Oh, yeah, sure, please continue.
Senator Adams, just a couple of other things. First of all, I kind of touched on this before. I deal with this a lot and have for years, and it's just incomprehensible and mind-boggling what some of our children in our Commonwealth have to go through at different stages of their lives. It's certainly not acceptable, but for most of it's not even understandable. There's a gap in understanding for most of us in our normal lives to have to put ourselves in the position of what some of these children go through just to reach adulthood, regardless of the impact those experiences have on their own adulthood. So thank you so much for your hard work in bringing this. It's something that is just incredibly needed and really touches a lot of our areas in our society. I have a couple of questions. Going to the fictive kin inclusion. Thank you for doing this. We have a lot of people raising children that don't have a direct blood or legal tie to their child, and oftentimes they are the most responsible, stable impact in that child's life. All too often, all of the direct family members are involved in whatever problem is causing the underlying grief, and to be able to broaden this out will be really helpful for the child. Was the goal of this to take this more, to be able to expand our definition of relative placement with the cabinet so we could have additional options for placement to limit out foster care? Was that one of the extensions of this that we were trying to accomplish?
Yes, and the overarching goal is to keep that family intact. I mean, in some way, shape, or form, because when you extract that child or those children from somebody that has some sort of relationship, it's devastating. I mean, I've listened to the foster kids talk about their one goal in so many instances is to get back with that family in some way, shape, or form. They have to heal that family. And so we just feel that this expansion is the smartest and most compassionate way to keep that family together and start the healing.
Thank you. Mr. Chairman, I have one more if that's okay. And you were discussing the inclusion of moderate risk into cabinet involvement for a preventative intervention model, I guess, is that sort of thing. And I apologize if I put you on the spot here. I don't intend to. I read through this and I didn't really think about it until I started listening to your presentation. Has there been any discussion on touching the drug abuse aspect? So many of the cases that we see in the court system I would say probably off the cuff number, 80% or more, the core etiology of this and the cause of this is a drug issue. And it's going to be a very difficult challenge for our social workers to go in on a preventative model where they need to address the drug issue when the parents are going to be naturally denying or hiding the underlying drug problem. And I just wondered if there was any discussion on how to address the drug abuse issue that is so prevalent in these.
You know, and I think that to answer your question, not specifically, but generally, that's part of the reason for the expansion of that to include moderate, is so that you're not getting them at the absolute depths of despair, that you're starting to identify that family who has an opportunity to be healed through addiction recovery services or what have you, that we can start to, rather than just blow the family up, here we are, we're trying to keep them together, we're going to try to get them the services that they need, we're going to try to get them the help that they need. And I think by opening up that definition to moderate will really help us start to influence these families in a positive way rather than having the most dramatic outcome for them, which is separation.
Thank you, and thank you for your time on this. Thank you, Mr. Chairman.
Thank you, Senator. Senator Carroll.
Thank you, Mr. Chairman, and thank you all for the presentation. And made some comments a couple weeks ago about the Commonwealth's the need that we have as a Commonwealth to deal with some of the basic issues in our state. Child abuse being one of those, where Chairman Alvarado mentioned that we are the worst in the country. And so, Leader Adams, I can't compliment you enough for this, and this is just one of those areas that we must focus on as a state, as well as substance abuse, poverty, all the other issues that unfortunately define us as a state, when the reality of it is we have so much to offer in this Commonwealth. We have got to deal with these basic issues before we do anything else. And so I commend you for that. With the Child Advocacy Centers, and I've had the opportunity over the years through my career to work with the centers, and I understand the value of them. As an investigator, I can't stress enough the value of having a trained physician to do these exams. These are the most difficult cases there are to prosecute, and having the evidence collected properly, forensic interviews being done properly, all evidence that later is admissible in court is crucial to the prosecution. So these centers provide an invaluable resource. My question is, I know these centers are regional, and I know in our area there is a concerted effort to reach out to all counties in the region to make sure that those services are available and that the people in those counties know. Is that something that some of the centers struggle with what Senator Givens stated? Those services are available to the residents of his county. I know they might have to travel a couple counties over, but how much emphasis is put in each center on the efforts to reach out, to educate the families, the communities of that region on the services that are provided?
So I can add that child advocacy centers across the state have family advocates that help support and help make sure families know what the process is and sort of walk along with them through the entire way. Caroline Rochelle is the head of the network of child advocacy centers of Kentucky, and she could not be here today. I'm sure, have no doubt, she could probably answer that much better than me. But each child advocacy center does have family advocate staff or time of staff that really helps those families. The bigger question of how do we share the great information about child advocacy centers across the state as a whole, each of us really uses that social media presence. There's no cost to that. And then just working with the folks in the community. Every one of the child advocacy centers works very closely with partnerships with law enforcement in those areas, to your point, because some of these cases may have criminal charges, may have court down the road. So it's critical that we're developing good working relationships, not only with our wonderful medical professionals, but also the law enforcement in every one of those counties, so that we're able to work with those. And each of us also works with multidisciplinary teams. And so that may include mental health, physicians, law enforcement, social workers, and schools and other supports to actually understand what's happening with those families. And we're there doing that so that everyone is held accountable for their role. So maybe that will help with some of the question. Does that help?
Yes, ma'am. Thank you. Thank you, Mr. Chairman.
I think your point is well taken, and I think that Senator Givens, Senator Howell, you all have good points, and I think that's really one of the challenges. It's probably a financial challenge as well as just a geographic challenge. But I think as we are able to serve more children, hopefully with more money, I mean, one of the things we really need to do is think outside of the box. For some of these kids that, and this is probably another issue for another day, but we have to think outside of the box is how we're going to reach these kids that have transportation issues. We do have, gas cards for kids to come, and Pam's point about the multidisciplinary team, every county is required to discuss their sexual abuse cases at a multidisciplinary team. So those teams should know that the Children's Advocacy Service Centers exist and what their services are. But reaching out to people that have transportation issues or are farther from those centers is a challenge that we need to address. And I think you're right. In this day and age, it may be the time to really rethink how people are going to get to us, and maybe there are some models where there's more mobile units or outreach units, and that's something that each center really has to start to think about in the future.
Yeah, if I remember correctly, our center has actually recently purchased a mobile unit for these types of services.
Mm-hmm.
Yeah, thank you.
Thank you. And I would encourage all members, if you haven't visited a CAC, it'd be worthwhile to go tour, meet the folks that are there to realize the good work that they do. Senator Meredith.
Thank you, Chairman Alvarado, and appreciate the testimony this morning. Met with some of your people yesterday and really received a great education. And I reminded them that, supposedly Mark Twain said that when the world came to an end, he hoped to be in Kentucky because everything happens 20 years later. And you mentioned this happened in 1980 and in 1990. Well, we're right on schedule, it looks like. But I will commend you on your ask. Quite truthfully, I think it's too small. And the reason I say that is we've had a lot of ask during this interim session. We never measure the cost of doing nothing. And I think if we did, it would be we would be staggered by it. I think you've got to be bold. We have to be aggressive. And I see no reason in the world not to do this $2 million because, again, it's a match, which means our portion is going to be, $600,000. I can assure you there's places in the state government we'll spend that within an hour and have no return on our investment whatsoever. So I understand what you're doing. I would hope this is just a start, that we could certainly broaden this network. We need to. There's not a better investment than in our children. And I know from inappropriate use of services, it happens every day that they're going to ERs when they could be coming to you folks. And the cost of that we could address that. We'd be amazed at what we could fund. So I thank you for your very reasonable request, Senator. I thank you for this obviously tragically needed bill and move forward, but hopefully it'll be a new day for exploited children in Kentucky. But thank you for being here today.
Thank you, Senator. Any other comments? If not, we'll entertain a motion on the bill. We have a motion by Senator Givens, a second by Senator Howell. Madam Clerk, please call the roll.
Senator Rocky Adams.
Aye.
Senator Berg.
Aye, and I'd like to say thank you, bless you. This is just a labor of love that shows and is well needed. Thank you.
Senator Carroll.
Aye.
Senator Givens. Senator Harper Angel.
Explain my vote, Mr. Chairman.
Please proceed.
Senator Rocky Adams, I served on the interim task force with you, and this is an excellent compilation of all those meetings. It's very comprehensive, and I commend you on your dedication to the children and the safety of the children of the Commonwealth, and you are to be highly commended for this work. Thank you.
Senator Howell.
Aye.
Senator Kerr. Senator Meredith. Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye, and I'm going to explain my vote as well. Actually, the matter passes 11-0, but again, we talk about a lot of things in the General Assembly. The most long-lasting investment we make is in our children. And if our children suffer trauma of any type, that extends for generations, plural, because their children often will suffer them. We know the consequences of this. This needs to be our main focus as a General Assembly, is getting this right. This is a great bill. It's the first step, not the last step. So we begin with this, and I hope to see more of this coming forward, and I hope to ascend in our rankings where we become the safest place where kids can be raised. We're trying to make it the best place, for lots of other reasons, but the safest place for children to be raised needs to be Kentucky. The matter passes 11-0. It'll be reported favorably to the Senate floor. Senator, congratulations. Thank you all for your attention today. There's no other matters. We stand adjourned.